So, ma'am, we are starting the session for today.
Yeah,
Good
sure.
evening and welcome to one and all. I'm Rituparna from Clearnet, the designated session assistant for a seamless experience. And Clearnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clearnet is very proud to be digital partner for this event named Case Discussion on Cardiovascular System organized by the Indian Academy of Pediatrics, Gujarat. So without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Neha Patel, a well-known professor and head of the department, GMFRS, MCH, SOLA. She is also one of the noted project coordinators of this program. Over to you, ma'am. Please proceed.
Thank you. And thank you, Clearnet, for providing this platform. I welcome all of you to the e-Gurukul Pathshala, the most favorite program of PG Clinic. Today we have case discussion on the cardiovascular system. And for that, we have two very well-known experts with us, Dr. Sushil Tripathi. Sushil sir is a renowned cardiologist and he is a director of cardiology at Arogyam Heart Clinic in Kandivali, Daisar, Mumbai. He is also attached with many of the other hospitals like Namaha Healthcare, Wockhardt Hospital, Thanga Hospital, Malad, Riddhi Vinayak, and the Baba Municipal General Hospital. He has many published papers on her name. So I welcome Sushil sir.
Good evening to everybody.
Our another expert, Dr. Vikas Arya. Sir has done his FNB Pediatric Cardiology from the Fortis Escort Heart Institute, New Delhi, and the MD Pediatrics from Gwalior. He is at present an assistant professor at SNMC, Jodhpur in the Department of Pediatrics. His special interests are 3D echo, fetal echo, invasive cardiology, and the pediatric cardiac genetics with all types of device closure. So I welcome Vikas sir. Our today's presenter, Dr. Rajat, and his mentor, Dr. Prashant Prabhu. Prashant sir is associate professor in the Department of Pediatrics at Government Medical College, Goa. I welcome both of you, and I also welcome our project in charge, Professor Dr. Yogesh Parikh sir, Vice President, Central IIT, West Zone. Welcome, sir.
Thank you, madam. Carry on.
So with this introduction, I give all these. So for the case presentation, we are missing today our Baldev sir as he is busy with his personal commitment. But we are having two renowned experts and the case presentation will go under their expertise. So with this, we can start the case presentation. So Rajat, you can share the screen.
Yes, ma'am. Ma'am, I can start.
Yes, please.
Yeah.
I request both the experts to ask the question wherever they feel it necessary. And also, there are other students who have joined, and they can also ask the other students for making it more interactive. So you can start, Rajat.
Yeah, thank you, ma'am. So we have patient XYZ, 13-year-old male, resident of Margao, Goa, born out of non-consanguineous marriage.
Rajat, it's
was
not
brought-
full screen. Rajat, it's not full screen. Can you make it in a slideshow or full screen?
Yes.
There is a symbol of full screen or the slideshow in the lower part.
Down
Where-
and on the right side.
Yes, on the right side. So click on it.
Where you minus or plus, you zoom in or zoom out, na, just on the left side of it. Just click on it, it will become full screen.
Go to the lower bar. Go to the lower bar. Lower bar. Yes. Now go to the right side. Go right side. There are many symbols. Yes. So now, yes. That is zoom. Go to left and near the zoom, there is a symbol of screenshot. No. Still 1, 2, 3. Third symbol. Still another. Yes.
Yeah,
Yes.
that's the one. That's the one, Rajat.
That's one. Yeah. Okay. Go on.
Yeah, thank you. So a patient, Mr. XYZ, 13-year-old male, resident of Margao, born out of non-consanguineous marriage, was brought with chief complaint of joint pain on and off since 4 months, chest pain 1 month back for 4 days, difficulty in breathing 1 month back for 4 days, fever 1 month back for 3 days. The history is given by mother and is reliable. The child was history of presenting illness. The child was apparently all right to 4 months when he started experiencing joint pain, initially noticed in the right elbow joint, followed by the left with subsequent clearing of the right-sided pain. This was then followed by the involvement of the right and the left knee joint in the similar fashion. Each episode would last for about a week and then subside, following which the child used to get frequent low-intensity knee joint pain lasting for few days with no limitation of daily activity. The episodes aggravated by physical activity but subsided with rest and analgesics. The joint pain, as per the mother, subsided within 2 days post-admission. There was no history of any joint swelling or restriction of joint movements. There was history of chest pain 1 month back, insidious in onset, undefined character, initially started in the left precordium radiating to the left arm, the left forearm and the neck. The pain persisted throughout the day with no diurnal or postural variation. The pain was experienced even at rest with no aggravating or relieving factor, as well as no change with inspiration or expiration. There was history of difficulty in breathing 1 month back, which was insidious in onset, noted even at rest to such an extent that the child's daily routine was compromised. The breathlessness would aggravate when the child would go to sleep, with history of frequent nocturnal awakenings. This was associated with intermittent episodes of palpitation. The chest pain, breathlessness, and episode of palpitation, as per the mother, lasted for around 4 days and subsided within 2 days post-admission with medical management. The child is asymptomatic since then. There was also history of fever 1 month back, insidious in onset, non-documented, associated with chills and rigor. The fever would subside temporarily with medication, but then would recur again. The fever persisted for around 3 days and the child is afebrile since then. In negative history, there was no history of swelling in the lower limb, no history of decreased urine output, no history of any syncopal episodes, no history of altered sensorium, no history of noticing swelling near the elbow, the lower legs or neck, no history of noticing any rash, no history of any involuntary upper or lower limb movements. There's no history of any tender digital swelling, no history suggestive of petechiae or purpuric rash, no history of noticing weakness on one side of the body or face, no history of noticing any tonic-cloning movement, no history of poor oral hygiene or any dental procedures or any surgical procedures. In the past history, at 10 years of age, the
One
child
minute,
had-
Rajat. 1 minute, Rajat.
Yes.
So, with your chief complaints, what is your initial impression about the child?
Yes, ma'am. So this is a 13-year-old child who is presented with on and off joint pain with acute onset of chest pain, breathlessness, and intermittent episodes of palpitation. Uh, ma'am, as per this, one possibility is it's a cardiac case with probably most can be with etiology most likely to be a rheumatic heart disease.
Okay, so Mimi, can
So Dr. Rajat,
Yes, sir.
your chief complaint was only joint pain. You said that chest pain and dyspnea was 1 month back. For how many duration? How much duration?
So 4 days.
4 days in that they subsided on its own.
So it subsided with medical management. So after post-admission, within 2 days post-admission with medical management.
So child admitted 1 month back with the complaint
Yes,
of
sir.
joint pain.
Yes, sir. Yeah.
And joint pain was not subsided, but the other complaints were subsided.
The joint pain has also subsided. So post-admission, the joint pain has also subsided 2 days post-admission. But the history of joint pain on and off is since 4 months.
Since 4. Okay. So which type of joint pain you are expecting this?
So this is the joint pain here. So in the history as per the mother is most likely a migratory type of polyarthritis, because it would remain in one joint and the pain in that joint would completely disappear and involve the other large joint.
Usually it starts from the leg and then it involve other joints, means starting from ankle and then knee and then elbow. In your case, pain started mainly from right elbow.
Yes, sir. The initial 4 months back, sir, the pain had started from in the elbow joint with knee. But then after that, since last 2-3 months, the pain has been intermittently involving the knee joints only. There's no elbow involvement, sir. Mainly the knee joints, the complaint is mainly the pain involving the knee joints.
So it is only a pain or it is involving with swelling?
Sir, no, there is no history of any swelling or no history. There's history of mild restriction, not severe restrictions. So only mild, like the child is having slight difficulty in walking when during the episode of acute pain. Otherwise, there's no swelling, no joint deformities, sir.
So it's a polyarthralgia and then polyarthritis, no?
Polyarthralgia, yes.
So for that you have taken some negative history.
So negative history as per the said based on the complaints of the this arthralgia and the cardiac based on chest pain, palpitations, and breathlessness, like most likely it would be a cardiac cause. And also after taking the history, so in the past history also there is a significant history. So I have asked in terms of cardiovascular system only.
Okay.
Okay, so Rajat, if you don't know the past history till now,
Yes,
and
ma'am.
you have the history of joint pain, so what are the other differential diagnoses except the rheumatic which you are or cardiac you are thinking of, other causes of joint pain?
Ma'am, one differential can be a causes of joint pain, ma'am. It can either be secondary to some viral illness such as dengue or chikungunya, or as a manifestation of juvenile idiopathic arthritis.
Okay, any other viral,
Uh,
except viral, any other thing which can affect the joint also?
Ma'am, there are certain bacterial infections also like brucellosis, but they are bit rare. Brucellosis can also come with arthritis, ma'am. And even infective endocarditis might present sometimes with joint pains.
No,
Okay.
infective endocarditis is always present with the high grade fever.
High grade
First,
fever.
without fever, Any infection will not present.
Yes. And connective tissue disorders such as SLE and those are also associated with arthritis in this age.
Okay. The another complaint which was very much prominent was the chest pain in your history. So what are the causes of chest pain in children?
Ma'am, from outside to inside, so involving the skin, it can be either cellulitis or any abscess. Then in the subcutaneous tissue, it can be any subcutaneous tissue, subcute tissue infections. Then deeper one can be osteochondritis or any inflammation, any osteomyelitis or osteochondritis. Then it can be a musculoskeletal pain. Then as we go inside, we have pleuritic type of chest pain, which is seen in pleural effusion, or then pericarditis and involvement of the heart in the form of any myocarditis, ma'am. Or then other causes of joint pain, other causes of chest pain can be GI cause such as gastroesophageal reflux, or we can have a vascular cause like acute dissection of aorta.
Very nice, Rajat. You have described it very nicely from inside to out. So may
Yes,
I ask
thank you.
other students that is there any other cardiological or the congenital heart disorder which can cause the chest pain? So other students, please. Nihal or Samruddhi, can you answer? So Rajat, do you have any idea?
Ma'am, can you please repeat the question, ma'am?
So any other congenital heart disease which can present as chest pain in the child? Or more specific, generally in adult, the chest pain are because of myocardial infarction if we take
Myocardial
about the
infarction.
cardio. Yes. So
Ma'am,
yes.
Ma'am, there's one condition, Al-Kappa, ma'am, that can present as a MI in children, ma'am. Anomalous
Yes,
left coronary artery arising from pulmonary artery.
So Dr.
Oh.
Rajat, so doctor, sorry for interrupting, but when do you think Al-Kappa usually presents? What is the
So
most common age of presentation of Al-Kappa? It usually presents at the age of 3 months. So
3
3-month
months.
old child will not give you presents with the chest pain, I think.
Yes, yes, sir.
So most common age is Al-Kappa is presenting at the age of 3 months. Myocardial steal. So that child will present with a congestive cardiac failure. So
Yes.
your question is, if it is cardiac chest pain and it is not non-coronary, the commonest causes are pericarditis, mitral valve prolapse syndrome, Eisenmangerization of congenital heart diseases, or a idiopathic pulmonary artery hypertension, or a aortic stenosis, or hypertrophic cardiomyopathy. These are some commonest cause of chest pain in the children.
Yes, sir.
Apart from this, if you go to the local side, it is the costochondritis, or also called as Teat syndrome. So fracture ribs, peptic ulcer diseases. Pertaining to the your case, why do you think there is a chest pain? So chest pain points towards which rheumatic heart disease? I want to ask.
So chest pain, so it can suggest involvement of myocardium or pericardium, as myocarditis or pericarditis, which can occur in rheumatic fever,
Okay.
or it might be a secondary to involvement of the aortic valve, aortic regurgitation, mostly the volume overload lesions.
Very good. Very good. Very good, Dr. Raja.
Thank you.
Okay, so we are going ahead with negative history. So Rajat, can you explain one by one the history you have taken to rule out with what diagnosis was there in your mind, and you have taken this negative history to rule it out?
Yeah, yes. So, ma'am, mainly my negative history was based on after going through the past history. So, based on past history, ma'am, so as per the child is presented now with acute onset of chest pain, breathlessness, palpitation. So, in order to rule out heart failure, I have asked for no history of swelling in the lower limb or decreased urine output to rule out the right heart failure feature. Syncopal episode altered sensorium will mainly go towards the left heart failure. Ma'am, then history of noticing swelling near the elbow, lower legs, neck. This is mostly the subcutaneous nodules. Noticing skin rash, ma'am, is erythema marginatum, and involuntary movements is chorea. So this is to rule out the acute recurrent rheumatic fever, ma'am. Recurrence of a rheumatic fever. And history of noticing tender digital swelling, petechial or purpuric rash, or weakness on one side of body, tonic clonic movements. These are for infective endocarditis, ma'am. Because on past history, the child has undergone a mitral valve replacement. So in a child with a prosthetic heart valve who's presenting with fever and chest pain, breathlessness, palpitations, to rule out infective endocarditis as etiology. So the third negative history is towards that man.
So, yes, you know the past history, and that's why you are again coming to the negative history and ruling out other. But even if the child has not gone for any of the surgical intervention, we need to rule out the infective endocarditis in a patient, and you are right in doing all the things. Any other comments, Vikas sir and Sushil sir?
In your history, you are also described about child getting out of sleep with the becoming breathless.
So yes.
So is it paroxysmal nocturnal dyspnea?
So the exact event of that paroxysmal nocturnal dyspnea, so I couldn't obtain from the history, but she used to say that there was frequent nocturnal awakenings. But the exact as per the definition, so exactly the history I couldn't obtain from the mother.
So what is paroxysmal nocturnal dyspnea and how it presents?
It usually presents when the child goes to sleep or in the recumbent position, that the child will suddenly wake up during night and will ambulate for some time, then feel relieved, and then again he goes to sleep.
So
Rajat,
Yes,
the-
sir.
as per your history of preventing illness and the negative history I was listening, child has undergone a mitral valve surgery, and now after some time he is having a recurrence of fever, and you are suspecting a rheumatic fever. So I want to
Yes, sir.
ask, how common is rheumatic fever recurrence after the first episode, and was child on some penicillin prophylaxis during this period?
So actually, the after that the episode after the mitral valve replacement, sir, the child was not on any penicillin prophylaxis. Uh, but 4 months back, sir, when the child had presented with episode of joint pain, that time the child was started on penicillin prophylaxis, sir. So since last 3 months, the child is on penicillin prophylaxis.
So how common is recurrence of rheumatic fever when the child is not on any penicillin prophylaxis?
The exact percentage, I'm not sure, but 30 to 50%.
And secondly, why not you are suspecting infective endocarditis in the background of some mitral valve? There is a prosthetic valve you are talking about.
Yes,
So
sir.
if any child with prosthetic valve comes with fever, the first thing to my mind will come is infective endocarditis.
So yes, sir, the infective endocarditis is also one of the possibilities. So the negative history I asked in terms of infective endocarditis as well.
All right.
Yes.
Okay. So go ahead, Rajat, for your other history part.
Yes, ma'am. Thank you. In the past history, at 10 years of age, the child had first episode of chest pain with joint pains which were migratory in nature. However, they were managed with analgesics and the patient was asked to follow up 3 months later, asked to follow up. So 3 months, the exact episode semiology, ma'am, couldn't be obtained from the mother. So 3 months later, the child had an episode of sore throat, followed about 2 weeks later by another episode of chest pain with migratory joint pain. For this complaint, the child was shown to a private practitioner and then referred to a tertiary care where a echo was done and parents were told that a child had a heart disease for which urgent surgery was warranted. The surgery was planned 4 days later, which was a valve replacement, and surgery and the post-surgical course was uneventful. Then at 13 years of age, at this time, the child was not started on any penicillin prophylaxis. At 13 years of age, the child was readmitted in view of severe joint pain. However, no joint swellings were noticed and there was no limitation of activity noted. The child was managed conservatively. At this visit, the child was started on penicillin prophylaxis and since then on 3 weekly IM injections. On
Is there
treatment,
is the child on any blood thinner?
yes, the child is, sir, in treatment history, I'll be telling that, sir, now.
Okay, okay.
Yes, sir. The child was started on TAP escumerol since the time of surgery and is being continued till now. The compliance with the treatment is ensured and patients parents monitoring the PT-INR on monthly basis. No signs and symptoms of the toxicity as of yet. Then the child was also started on TAP furosemide and spironolactone since the time of surgery. The child is also receiving TAP aspirin at the time of surgery, but then it was omitted by in next 3 to 4 months. And injection penicillins have been given after every test dose on 3 weekly basis. No adverse events have been seen till now. Post admission, the child was detected to have high BP and started on TAP amlodipine. So currently the child is on TAB amlode, TAB escumerol, furosemide and spironolactone and 3 weekly penicillins. Then in the birth history, the mother was a booked case, received iron, calcium, folic acid supplement. Antenatal scans done were normal, within normal limit. The first, second, third trimesters were uneventful. Baby was born at term by spontaneous vaginal delivery, vertex presentation. Birth weight was approximately 3 kgs. Baby cried at birth, no resuscitation required, and postnatal course was uneventful. In developmental history, all the milestones achieved are appropriate for age. The child is doing average in academics, currently in class 7, and good interactions with family members and peers. This is the family history chart. Born out of non-consanguineous marriage, and there's no family history of any acute rheumatic fever or rheumatic heart disease. The child has 4 siblings, all 4 are males. There's no history of any rheumatic fever or heart disease in any of them. Then coming to socio-economic history, there are 8 members who are present in the family, all stay under one roof. So overcrowding is present. However, child rearing practices are good. Diet history wise, there's 710 kilocalorie deficit in diet and 12-gram deficit in proteins. Immunization wise, the child is immunized for age. So the summary is 13-year-old child, known case of valvular heart disease, status post-valve repair on 3 weekly penicillin prophylaxis, now presenting with acute onset of chest pain, breathlessness, palpitations with fever, no history suggestive of any of infective endocarditis, No history suggestive of heart failure. No history suggestive of acute rheumatic fever recurrence with recent onset of hypertension. In examination,
So Rajat, from the
Yes.
history, you are having impression of the patients having probable diagnosis of rheumatic heart disease with the
Yes,
valvular regurgitation and with surgery, which is of valve repair, and now query recurrence or query infective endocarditis. Okay.
yes, ma'am.
Okay. So now tell us what are the criteria on which you will have the diagnosis of first rheumatic fever first episode.
So rheumatic fever, ma'am, for the first episode, it is 2 major plus 1 minor or 3 minor criteria. 3 minor. So this criteria, ma'am, depend on whether the patient is in a high risk zone or a low risk zone. So if it's a low risk zone, the major criteria we have carditis, arthritis, chorea, subcutaneous nodules, and erythema marginatum. But the change is in the low risk area. So we consider only polyarthritis as a major criteria. In minor criteria, we have fever in low risk zone, a fever which is more than 38.5 degrees Celsius with a ESR of more than 60, more than equal to 60, CRP of more than 3, with an with monoarthralgia, polyarthralgia, or monoarthritis. This is in a low risk zone. Then in a high risk zone, the major criteria remains the same. That is the carditis, chorea, subacute nodules, erythema marginatum. But in arthritis, we are having monoarthritis, polyarthritis, and even polyarthralgia is a major criteria. In the minor criteria, the changes are fever, which is more than 38 degrees Celsius, and ESR changes more than equal to 30. The CRP remains same, that is 3. And in arthralgia, it is monoarthralgia.
Okay. So was your child fulfilling all the criteria you required for the first episode?
Yes, ma'am.
Which were the criteria on basis of which you diagnosed it as a first episode of rheumatic fever?
Ma'am, actually, the valvular heart disease, ma'am, the already mitral valve replacement has been done 3 to 4 years back, ma'am. So that time, the child presented mainly with joint pains as per the mother. There was there was history of chest pain and migratory joint pains. That time the child had fever also. So during that time, when the child had arthritis, carditis was also there, and maybe the child had fever. So 2 major and 1 minor criteria based on that.
Okay, Dr. Rajat, what do you think why there is hypertension in this child?
So hypertension can be secondary to a new valvular lesion developing in the background of rheumatic heart disease. Most likely it can be, sir, secondary to a aortic regurgitation or any volume overload lesion.
But in a child like you can suspect some renal cause also for hypertension, and the history you are describing could be hypertensive heart failure. Why it is not a nephritic syndrome? And even if patient had a rheumatic heart disease, underwent surgery, he is always susceptible for a nephritic syndrome or acute glomerular nephritis, something. Have we asked for history suggestive or to rule out any acute glomerular nephritis? Because child is coming from a socioeconomic background where he's susceptible for rheumatic fever. He can be susceptible
sir.
for the nephrogenic strains of pyoderma of streptococcus also. So he's always susceptible for AGN, and the
Yes,
hypertension could be the one of the presentation.
yes.
It's not
Sir,
always aortic regurgitation presents with recent onset hypertension. That also in the patients of rheumatic fever. If there is a valvulitis involving the aortic valve, it's very rare to present that child as a hypertension.
yes, sir. So as per the history, actually, there was no history of any decreased urine output or swelling of bilateral lower limbs or reddish cola colored urine. There was no such history, sir, for glomerulonephron.
Okay.
Yes.
So, any other student can tell me that out of all these major zones criteria, which two doesn't go together? Students, please participate in the discussion. So, Dr. Anga, which two criteria doesn't go together?
Carditis and chorea.
So, how do you define chorea in rheumatic? So, what are the characteristics of rheumatic chorea? That is what I'm asking. Any other students, please? Make it interactive. Other students can take part in discussion. So, okay, Rajat,
Yes.
you can take this. So, characteristics of rheumatic chorea.
Ma'am, the chorea is described as synonyms chorea or Saint Vitus dance. So it is semi-purposive, quasi-purposive movements, ma'am, and it the described as a hand wriggling movement. So basically, there's a so they are quasi-purposive, involuntary, quasi-purposive, and mainly manifest as a hand wriggling movements, ma'am.
What do you
And
mean by quasi-purposive?
quasi-purposive is when you ask the patient to do, the moments get exacerbated, man. Like the milkmaid sign or the tongue protrusion. And these moments, man, tend to disappear during the time of sleep. More common when the child is doing some activity.
So, why these two doesn't go together, carditis and chorea?
Ma'am, actually ma'am, actually it is the arthritis and the chorea, ma'am, which usually do not go together.
So, why?
Ma'am, actually the arthritis in rheumatic heart disease, ma'am, is so painful and restricting the movements of the joint that the chorea cannot get manifested, ma'am. And also arthritis is a early feature, whereas the chorea, which is there, is usually seen in 3 to 6 months. So by that time, the arthritis has already subsided, ma'am.
Yes. So, one is the initial feature, which generally presents as the first symptom, and the another is the last symptom, which generally presents in a rheumatic disease course. Okay. Any other thing our experts wants to go for?
Go on, continue, please.
Yes. In general examination, the child was conscious, cooperative, well-oriented, with time, place, and person, lying comfortably on bed with the IV cannula in the right hand. Vitals or temperature was 37 degrees Celsius, checked in the right axilla. The heart rate was 110 beats per minute, regular, high volume, water hammer character with no radio-radial or a radio-femoral delay. The respiratory rate was 26 per minute abdominal with no use of accessory muscle of respiration. Abdominothoracic breathe. Blood pressures in the upper limb was 130 by 30 millimeters of mercury. In the lower limbs, they were 190 by 30 millimeters of mercury. The saturation checked were 95 to 97% in all four limbs, and the JVP was recorded as 7 centimeters at 45-degree inclination. Anthropometry wise, the height is 127 centimeters, which is less than third
Rajat, please,
centimeter.
please stay at the vitals and yes. So
Yes.
our experts.
Dr. Rajat, you said it is a high volume water hammer pulse in character. What is that, and how do you diagnose that water hammer pulse?
So water hammer pulse, we feel, so we actually feel at we hold the patient's hand and then lift it in the high way, like lift it, and then we feel for the thrust of the pulse over our palms.
So why there is water hammer pulse and which organic valvular heart disease you see that water hammer pulse?
So basically, water hammer pulse is a water hammer character of the pulse is a sign of high output states. So in all the cases where there are high output states, the pulse will be a water hammer in character.
In most of the high output states, there is usually a bounding pulse. This typical of water hammer pulse is seen when there is a aortic runoff. There is a leakage of blood somewhere. So whenever there is a severe aortic regurgitation, there is a high LV volume. That's why there is a bounding pulse. But because of aortic regurgitation, the whole blood is going back, and there is a sudden drop in the pulse. That is a sign of peripheral sign of the aortic regurgitation. So, can you say a few more signs of peripheral signs of aortic runoff that you know?
So one is so starting from the head to toe. So at the initially we are having in the head titubation. So with each pulse there is nodding of the head. Then after that there is a in the eyes we are seeing the then there's lighthouse sign, which is alternate blanching and flushing of the forehead. Then the third one is the Landolfi's sign in the retinal artery pulsations we can see. Then
I think that is Baker's sign. I think Landolfi's alternate dilatation of pupil.
yes, sir. Yeah. Landolfi's is alternate dilatation and constriction of pupil with pulse. Yeah. Baker's is the retinal artery pulsation. Then, sir, we are having Corrigan's pulse, which is the bounding carotids.
And what is a Bispherian's pulse?
Sir,
What is Bispherian's pulse?
Pistorius pulse.
Bispherian's pulse, BIS, I think. Am I audible?
Sir, Bispherian's pulse is there's one upstroke in systole and one upstroke in diastole, sir. So this is feature of mainly HOCM.
No, yeah, there is something called as bifid pulse. So what you are talking about is a bifid pulse, which is seen in HOCM. I'm talking about Bispherian's pulse. Whenever there is a mixed aortic valve disease with aortic stenosis and aortic regurgitation, you have during one peak in because of aortic stenosis, you get a slow rising pulse. That is what we call as a tardus pulse. Plus, because of the significant aortic regurgitation, there is aortic runoff and there is a sudden drop. So there is a Bispherian's character, which is a characteristic of mixed aortic stenosis and aortic valve disease. Yeah, good. Go ahead.
So Dr. Rajat, you have described about the Hill's sign. So Rajat,
Yes.
you want to, will you tell more about Hill's sign? Where do you see? How do you see?
Ma'am, yeah, the Hill sign, ma'am, is the difference between the blood pressures in the upper and the lower limb. So basically, this is one of the sign in aortic regurgitation. So Hill sign, ma'am, that based on the difference in the blood pressures, normally it is less than 20 between the upper and the lower limb, with lower limb BP more than the upper limb. So based on the difference of the upper and lower limb BP, we can grade the aortic rigor. So if it is between 20 to 40, the difference, then it is mild AR. Between 40 to 60, it's a moderate AR, and more than 60, it's a severe AR.
Are you describing pulse pressure or you are describing the difference between
So the
upper limb
difference,
and lower limb systolic pressure?
so the difference between the systolic pressures in the upper and lower limb.
Okay, so go ahead now.
Go ahead.
Then anthropometry wise, the height is 127 centimeters, which is less than the third centile. The weight is 25 kg, which is again less than the third centile. But the BMI of the child is 15.5, which is normal. Then in head to toe examination, in the head, there's no abnormal size or shape. Eyes, there was a shallow appearance, no dysmorphism. Face, there's no facial dysmorphism, no abnormality seen, no other abnormality seen. In oral cavity, there's good oral hygiene, no dental caries, no tonsillar enlargement. In the neck, there was a prominent carotid pulsations, which are Corrigan's pulse. Extremity, there's a prominent brachial artery pulsation. So this is locomotor brachii, which is then no subcutaneous nodules were seen, no clubbing or splinter hemorrhages. In the skin, there's no petechiae or purpura, no rash. However, there's a midline sternal surgical scar. In the spine is normal, genitalia is normal. SMR staging is Tanner stage 2. No neurocutaneous markers. Systemic examination wise, CVS on inspection, the chest is normal in shape, bilateral symmetrical. No chest deformities are seen. Precordial bulge is present. Tracheal position is central. Apical impulse is seen in the sixth intercostal space mid-clavicular line. Visible neck veins are present. There's a midline vertical scar which is present along with the epigastric port side scars, both of which are healed by primary intention. There's no dilated chest vein or sinuses seen. On palpation, the trachea is central. Apex is felt in the left sixth intercostal space, mid-clavicular line, normal in nature. Grade 3 peristernal heave is present. Thrill is present in pulmonary and aortic area, and there is diastolic shock. On percussion, the right heart border corresponds to retrosternum, left heart border corresponds to normal cardiac dullness, and the dullness is noted in the left second intercostal space. On auscultation, in mitral area, there is a S1 click, click heard,
Ajay,
and S
sorry to interrupt
normal.
you. Can you describe the palpation findings again? Like you mentioned, the apical impulse is in the sixth intercostal space. How do you describe a apical impulse? Is it just a site you describe, or also like
So,
size
yeah,
and a contour?
so yeah, it is in the sixth intercostal space and it is well localized.
Okay, so what is the localized apical impulse and what is the diffuse apical impulse?
So,
What does it signify?
So localized apical impulse is when it's felt only in one intercostal space, when it's localized only in one intercostal space, while diffuse is usually 2 to 3 intercostal spaces.
Right.
In diffuse impulse, it usually diffuse apical impulse usually implies a volume overload state, while a well localized impulse usually implies a pressure overload state.
Right. So if you have a diffuse apical impulse, you suspect the LV enlargement or the LV dysfunction. So
Yes, sir.
because my initial examination, you were pointing towards some aortic regurgitation, so I would suspect a very large left ventricle, and then I would expect a diffuse apical impulse in such patients. Secondly, you'll also describe a contour. I mean, how the amplitude of the apical impulse is, whether it is sustained for the entire systole or it is only localized and it is not sustained, ill sustained. It occupies almost only 2/3 of the systole, right?
Yes. So this was ill sustained. Yeah.
You said there is a
And
diastolic shock present on palpation. What is that? And in your case, what hints it is giving to you?
So diastolic shock implies palpable P2. So it's suggestive of pulmonary hypertension, sir.
All right. Okay.
so what can you tell what is the difference between apex beat and apical impulse?
Ma'am, apical impulse is what we feel, while the apex beat is what we auscultate with.
Okay. And if you define it in a more refined way? Okay. In your case, the apex felt, it was whether LV type or RV type. How will you decide it?
Ma'am, as in LV type, RV type, as in because of LV dilatation or RV dilatation.
So how do you define that whether
So,
the apex? Yes, any
yes,
other
ma'am.
student?
Ma'am, if there is a LV enlargement, the apex will be pushed down outwards, whereas if it is RV type, it is down and out.
So what was there in your case?
Ma'am, in
What
this,
do
the
you think?
apex is shifted downwards.
Okay. Which part of the heart forms base of the heart?
The right ventricle.
Sure. RV forms the base. Because apex is formed by
LV.
LV. So there are two parts. Yes, someone answered. So Anish, I think. Anish, you can even talk. It's not necessary to write everything. You can even start your microphone and take part in the discussion. So it is RV and part of the LA. Both will form the base of the heart. Okay. Why there was parasternal heave in your case?
Ma'am, parasternal heave implies right ventricular enlargement, right heart enlargement. Ma'am.
Yes. So is there any, so do you think in as per your patient, what is the impression you are having after this palpation? The apex
Ma'am,
is left type and the parasternal heave showing right enlargement.
yes, ma'am. So, ma'am, this can be a case of a left-sided pathology with pulmonary hypertension and secondary to pulmonary hypertension. There could have been a right heart enlargement also.
Okay, go ahead.
Auscultation wise, in mitral area, there is a click heard. S2 was heard normally. There is a grade 3 pansystolic murmur, with no radiation and no added sound. Tricuspid area, there's a S1 click. S2 is well heard. Grade 3 systolic murmur with no radiation, no added sound. Aortic area, again, there's a S1 click. S2 is loud. Grade 4 EDM, no radiation, no added sound. In pulmonary area, there's a click with a loud S2, grade 4 EDM, no radiation, no added sounds. Other system examination is
Sorry to interrupt again. So if you go back to the auscultation, so you heard a click in all over cardiac area. What does that signify?
so the S1 click is mainly due to the prosthetic heart valve, which the prosthetic heart valve which is done, the mitral valve replacement.
So from your auscultatory findings, you can say the child has undergone a mitral valve replacement and not repair. And which type of valve he has undergone with replacement?
Most likely a metallic prosthetic valve.
Right, right. Good. So you also have a grade 3 pansystolic murmur in the mitral and tricuspid area. So what do you suspect? What are your interpretation of those murmurs?
Sir, in grade 3 in mitral could be secondary to the valve replacement. There would be the murmur, the leak through the prosthetic valve. In tricuspid area, the grade 3 pansystolic murmur could be as a functional murmur secondary to RV enlargement and a functional tricuspid regurgitation.
So how would you differentiate the pansystolic murmur of the mitral side versus the TR murmur?
So the pansystolic murmur of a TR will increase, will be more prominent on inspiration. On mitral valve will be more prominent during expiration.
There will be no respirophasic variation of the mitral valve. On RV, you rightly said that is called as Caravello sign. When you have increase in the intensity of the tricuspid murmur on inspiration, right? And okay. Yes, you can go ahead now.
So in respiratory system, air entry was equal on both sides, bilaterally clear. Per abdomen, soft and non-tender, no organomegaly.
You have on palpation, you have a thrill or aortic and pulmonary area.
Yes, sir.
So that was not shown in your auscultatory finding. If it is thrill, then it has to be a grade 4 systolic murmur in mitral area.
So no, the thrill was in the pulmonary and aortic area, sir. So the murmurs in those areas are grade 4.
Diastolic murmur reading. Okay.
Other system examination, RS air entry was equal on both sides, bilaterally clear. Per abdomen was soft and non-tender, no organomegaly. And CNS wise, GCS was 15 by 15 and tone was normal. So to summarize, here is a 13-year-old child, known case of valvular heart disease, status post valve replacement on 3-weekly penicillin prophylaxis, now presenting with acute onset chest pain, breathlessness, palpitations with fever, with no history suggestive of heart failure or acute rheumatic fever recurrence or infective endocarditis, with recent onset hypertension. On examination, noted to have high volume pulse with a wide pulse pressure along with a positive Hill sign, Corrigan sign, Trop sign, and locomotor brachii along with raised JVP. Anthropometry is remarkable for chronic malnutrition. CVS examination remarkable for precordial bulge with apex push downwards along with regurgitant lesions in aortic, pulmonary, tricuspid, and mitral valve. So diagnosis most likely is chronic malnutrition with acquired heart disease, most likely rheumatic etiology characterized by severe AR with a MR status post mitral valve replacement with pulmonary hypertension presenting with query recurrent rheumatic fever without infective endocarditis, not in heart failure.
Dr. Rajat, which MR you are talking about? Because child has already underwent a mitral valve replacement, you are telling. So what mitral regurgitation are you suspecting?
So secondary to the prosthetic heart valve replacement, there can be a murmur through the leak through the replaced valve.
So whenever you have a prosthetic heart valves, there could be a very physiological small intravalvular leak. There could be a significant paravalvular leak. So what is that is called as PVL, paravalvular leak, when you have when you will get some pansystolic murmur. But usually in 3 months time, it is usually because of secondary to infective endocarditis with some abscess or something near the sieving ring, and that will give away so easily. Otherwise, the paravalvular leak usually is a chronic phenomena which is seen mainly after 10 to 15 years of mitral valve replacement. So, occurrence of a mitral regurgitation, I mean the PVL, in 3 months' time, it's quite suspicious.
So the replacement was done 3 years back, so 3 to 4 years back at the age of 10.
Okay, okay.
Yes.
Even then, I mean, occurring of what are the complications that you expect in a child with prosthetic metallic valve? What complications are there?
Prosthetic, so one, it can be a nidus for formation of a thrombus, and it can lead to any thromboembolic state, or there can infective endocarditis, or child can have microangiopathic hemolytic anemias.
The most common complication in day-to-day practice that you are going to see with the metallic valve is the prosthetic valve thrombosis. That is why patient is on the blood thinners and vitamin K antagonists. Even with vitamin K antagonists, you can have a very labile INR because if many of the patients are not monitoring their INR and their dose adjustments are not done. So these patients are at very high risk for the prosthetic valve thrombosis. And the second one is the formation of pannus, though again it will take some time. The most important, I would suspect in such patients is what is called as prosthesis patient mismatch, because this valve was replaced in a small child, and this child is going to grow in near future, but the metallic valve size will remain same. So as his body surface area will increase, the requirement of cardiac output and stroke volume will increase. And this small valve will not able to sufficiently supply that stroke volume to meet his metabolic needs. And that is a situation where it will create a kind of acquired aortic stenosis, and the child is further present maybe 6, 7, 8 years down the line with the symptoms of LV outflow tract obstruction, and that is called as prosthesis patient mismatch. That is why in such a small child, one would be very skeptical to subject such child for any valve surgery. The best would be a valve repair rather than valve surgery. And the one complication we already discussed is a paravalvular leak, which is usually either in acute is because of infective endocarditis, or in the chronic is because of some sutures or dehiscence of the sieving ring.
Yes.
All right. Any other questions from the other teachers?
So why do you think, Dr. Rajat, that this child has developed AR after the initial surgery?
So one reason is the child was not started on penicillin prophylaxis for 3 years post surgery. So one possibility is acute rheumatic fever, recurrence of a rheumatic fever, or it can
Recurrence of
be as a
rheumatic.
part of the same progression of the valvular heart lesions.
Is it an acute AR or is it a chronic AR? My question is, do you understand this thing?
Yes, sir. So most likely this is a acute AR because the presentation of the cardiac features were acute. Like
Yes.
there was a history of 2 day the presentation was acute. 2 days history prior, 2 days prior to admission, there was a 2 to 3 days episode history of chest pain, breathlessness, and palpitations.
So child with the mitral valve replacement and then going for a severe AR, features of severe AR with the pulmonary hypertension most likely leads to acute AR. but the cause would be mostly is an infective endocarditis rather than something else.
Okay,
It
sir.
could not be a recurrence which can occur within a 2 days, within a very small period, as you have described it.
Yes, sir.
So what should be the duration of penicillin prophylaxis, Rajat, in any case of rheumatic heart disease?
So, ma'am, if there is no carditis, only if there's no carditis, so then we give for 5 years or 21 years, whichever is longer. In case there is carditis but no valvulitis, then it's 10 years or 21 is long. And in case there is a valve involvement, then it is 10 years or then it is for 40 years or lifelong.
Okay, very nice. So do you know what is the difference between the mitral valve repair and replacement?
Ma'am, mitral valve repair usually, ma'am, mitral valve replacement is basically there's replacement with a prosthetic valve, which can be a metallic or a semi-synthetic material, but repair is includes a valvotomy and this repair. Ma'am.
Valvotomy is done for which type of heart lesion? It is for
Mitral stenosis.
stenosis, yes. So it is for stenosis, not for regurgitation. And your
Yes.
patient had regurgitation, and if it could have gone for repair. So do you know what is the difference in, yes, so in replacement, whole of the valve is prosthetic. What happens in repair?
Repair, ma'am, the annulus is kept intact.
Yes, do they use anything for repair?
Not
Our experts
there's-
can comment something on repair because it is not much known in all the PGs. So please.
Basically, in mitral regurgitation, if you see the mitral valve, we have two leaflets, the anterior mitral leaflets and the posterior mitral leaflet. And there are three scallops in the both leaflets, the A1, A2, A3, and P1, P2, P3. So whenever there is a organic lesion in the mitral valve, for example, either a rheumatic affection of the mitral valve or there will be mitral valve prolapse. So whichever scallop is dehiscence, kind of prolapsing and lead to regurgitation, those can be sutured with one another. So kind of a mitral stenosis you are creating. The two scallops, the two opposing scallops, that is called as Alfredi repair, where the two opposing scallops are sutured to each other, and that will decrease the amount of regurgitation. In your case, I would like to subject this child for the mitral valve repair rather than replacement, because replacement have its own complication, and at this age managing those complications and the long-term complications we have discussed would be difficult.
Yes. Sir, is there anything like ring is used in repair? If the
Whenever the mitral valve apparatus has, as I talked, is a leaflet. In mitral valve apparatus also includes the mitral annulus and the chordae. So whenever there is a lesion, in adult population, the common reason is the dilated cardiomyopathy when the annulus is dilated, and that leads to incomplete coaptation of the two mitral leaflets. So in those cases, the annulus is the reason for the mitral regurgitation. So tightening or the annuloplasty would lead to a repair of the regurgitant lesion. While in rheumatic fever or mitral valve prolapse, usually the pathology is in the leaflet, and therefore in those patients, the annuloplasty would not help much.
So annuloplasty ring usually helps in tricuspid valve regurgitations.
Correct.
Well, in mitral valve regurgitation, we usually go for repair. And as sir has said, that we usually tie up scallops of the mitral valve rather than using mitral valve ring.
yes. So that was for students. That the repair is how the repair is done. Now, if we are going ahead with the case and further investigations.
So is there any X-ray or ECG?
Ma'am, yeah, investigations wise at diagnosis, 2D echo pre-op, there was a dilated LALV with myxomatous mitral valve with a severe central MR with a moderate eccentric AR, mild TR and moderate PAH with normal RARV and normal ejection fraction with thin rim of pericardial effusion. At the time of current,
Dr. Rajat, sorry to interrupt again. Just
Yes.
go back to your 2D echocardiography findings. So,
Yes.
what are the expected findings in rheumatic heart disease in the mitral valve? What echocardiographic features are characteristic of mitral valve rheumatic heart disease affection?
So in the acute setting of a rheumatic heart disease, there is a mitral regurgitation and chronically it involves to mitral stenosis.
Right. See, you have mentioned as a myxomatous mitral valve. This is a characteristic feature of mitral valve prolapse. Usually in rheumatic heart disease, the mitral valve, the motion is very restricted. There is a lot of fusion of commissural. The anterior and posterior commissures are fused. The posterior mitral leaflet is restricted in motion. The motion of the PML is restricted. That is, in fact, the very characteristic sign of rheumatic heart disease when you are doing a 2D echocardiography. And there is a stick-like movement of the anterior mitral leaflet. So this myxomatous thickening is very characteristic of mitral valve prolapse. So this 2D echo finding is not going hand in hand with your case. And secondly, the dilatation of LV is usually more common with MR. So if there is a dilated LV, you can suspect there is a single mitral regurgitant lesion and there is no associated mitral stenosis, because with mitral stenosis, the LV is not enlarged, only LA is enlarged.
Okay.
You can
Then
go
at
ahead.
that,
So
at that
go back to your echo findings.
yes.
So in an acute, any acute rheumatic heart fever, we usually found some rheumatic vegetations on the valve. As correctly said, as this disease progresses, we find the restriction motion of PML and then AML get prolapsed. And in some settings, we can find in this myxomatous mitral valve, like an acute MR, there could be some caudal rupture could happen in the case of rheumatic heart disease that can create sudden severe acute MR. But in other cases, usually it is a combination of MS and MR.
Yes, one more thing in your echo, there is normal RA and RV. While in your findings, there was parasternal heave and you were suspecting some pulmonary hypertension with hypertrophy of the RA-RV.
Yes.
So it wasn't found in your E2D echo.
Ma'am, this was the pre-op echo, ma'am, done at when the child was 10 years old,
years.
ma'am, prior
Okay,
to the
okay.
mitral valve
Okay,
replacement.
okay. Go
So,
ahead.
Dr. Rajat, you had a moderate AR at that time itself.
Why
When
it
the
has
Yes,
child
not
first
happened?
presented, he had a
yes,
severe MR and moderate AR. So, do you agree that whatever management was offered at that time of replacing the mitral valve was correct, or it could have been mitral valve repair, or if surgeon is very aggressive, it would have been the double valve repair? Leaving moderate AR in that patient, was it okay? What do you think? What are the guidelines that say? See,
uh,
whenever you have a mitral regurgitation or any regurgitant lesion in the heart, the first and most important thing is whether patient is having symptoms. And of course, your child was presented with symptoms. And symptoms may be because of rheumatic fever or rheumatic heart disease. The rheumatic fever symptoms will be there in initial phase when there is a carditis. And once the carditis settles, still, if the patient is having regurgitant lesion and the symptom, then that is the case where you think of surgery. And the surgery also, if patient is having LV dilatation, LV dysfunction, development of pulmonary hypertension or arrhythmias like atrial fibrillation, those are the cases where we'll think of surgery. And if surgery is contemplated, the first would be a repair. As we have discussed before also, it would have a lot of complications of the prosthetic valve. And now the child is in a big trouble because already underwent a one mitral valve replacement, and the redo surgery for AR would be very, very difficult because of a lot of fibrosis and many other things.
Okay, sir.
So repair at the first place would have been the better option, and repairing only one valve has probably placed the child in such a situation now where this he has to live with severe AR, or he has to undergo another surgery for the aortic regurgitation. All right, we can
Okay, sir.
proceed.
Thank you. Now, at the time of current admission, the CBC wise HB was 10 gram%. Total counts 11,000 with differential of 63 neutrophil, 22 lymphocyte, and platelet count was 2.93 lakhs. LFTs were within normal limit. RFTs were also within normal limit. The PT-INR APTT prothrombin time was 13.2 with a INR of 1.29, which was low. APTT was 32.8. The other test showed ASO titers of 1,967, which were high. CRP of 136 milligram per liter, which was again high. The blood culture sensitivity was sterile. The 2D echo done at this point of time was showing mitral valve prosthesis in situ. No valvular or perivalvular leak was seen. No thickened TV with a mild TR was seen. Severe AR, normal pulmonary artery pressures, normal LV function with no clot.
So, Dr. Rajat, there is no valvular or paravalvular leak in your echo findings. So, what is the reason for that murmur in the mitral area, the pansystolic murmur you are talking about?
Yes, sir.
Also, no evidence of PA, pulmonary hypertension.
Yeah, you had
Yes.
diastolic shock also in your palpation.
Yes, sir. The findings were actually prominent. There was a loud P2 with a dullness in second intercostal space, and so also the murmur was also heard in the mitral area. The pansystolic murmur was also heard.
See, with the presence of metallic valve and the click, it's very difficult to interpret the murmur in the different areas. Anyways, there is something called as dynamic auscultations to differentiate the systolic murmurs. So have you done dynamic auscultation in this child? What is dynamic auscultation?
So dynamic auscultation is done by using the various manuals such as Valsalva manuals and
What is Valsalva maneuver? How you do it, and what lesions will be differentiated based on Valsalva maneuver?
so Valsalva can differentiate basically it can differentiate a pressure HOCM from mitral valve prolapse.
See, how you ask a child to do a Valsalva maneuver? The
It's
simple way of doing Valsalva maneuver, you can keep your hand on the patient's or child's abdomen and ask him to push your hand. So ultimately, they'll end up doing the Valsalva maneuver. So whenever you are doing a Valsalva maneuver, the Valsalva maneuver has 4 phases. The phase 1, when you strain phase, there is a sudden increase in the intrathoracic pressure, and that leads to initially strain phase. There's an increase in the blood pressure, and this is almost 5 to 6 beats later is followed by fall in blood pressure because the intrathoracic venous return is fall, and the afterload is increased, so stroke volume is decreased, and that leads to fall in the blood pressure. That is called as active phase, and there is a reflex tachycardia. Then there is a third phase when there is a further fall in blood pressure because of the continued blowing of the Valsalva maneuver, and this is followed by the last phase, the relaxation phase, when there is again rise in blood pressure, and when there is a rise in blood pressure, there is bradycardia also. So these are the 4 phases. But when we are subjecting anybody for the Valsalva maneuver, we are concentrating on the second phase, when there is a reflex tachycardia. So all the systolic murmurs, be it anything, will be what will happen to the systolic murmur when we do a Valsalva maneuver. Because there is a fall in blood pressure, because there is a reflex tachycardia, all the murmurs will decrease in intensity. But while the murmur of HOCM, because there is increase in the afterload, so the gradient between the aorta and the subvalvular left ventricular outflow tract will be diminished, and therefore the murmur of HOCM will decrease, and so does the murmur of or click of mitral valve prolapse will also decrease. And the second thing you can do in dynamic auscultation is you can ask the child to squat. Squatting or standing from the supine position, or squatting standing again and again. So by doing squatting, we are actually obliterating the peripheral arteries, and therefore you are increasing the afterload. And that again, what I explained, will have an effect on the HOCM and mitral valve prolapse murmur. Secondly, you auscultate with different phases of respiration. As we were discussing, you had a pansystolic murmur in the lower left sternal border area, that is the tricuspid area, but you are also hearing it in the mitral area. So in a small chest, it is possible that you are hearing the tricuspid murmur in that area. So asking the patient to deep inspiration, if you see whether it is increasing in intensity or not. And sometimes patients are having ectopic beats, and you can hear the same intensity of murmur with after the ectopic beats. So most of the murmurs like aortic stenosis or HOCM, the intensity will increase after the ectopic beats. So dynamic auscultation is a very important part of the cardiac auscultation, and you should do it at the end of all the examination to differentiate the murmurs.
Okay, sir.
So do we have any X-ray or ECG, Rajat?
Also, one thing to add, if you have a painful signs of AR, Dr. Rajat, so if you have a peripheral signs of AR present in your case, so
Yes,
you can't have some acute AR finding. It has to be a chronic AR. And it is seen in your echo also that there is no normal PA pressures. So whenever there is a PA, means peripheral signs are present, you means auscultate it with carefully, that there should not be any signs of pH, because pH will only come, peripheral signs will only come once pH is gone. Acute phase is gone, then there will be a chronic phase, and then there will be a peripheral signs of AR only.
Okay, sir.
Am I clear, Dr. Rajat?
Yes, sir. Thank you, sir.
So Dr. Rajat, how will you manage this case now?
So now, so based on the history and the clinical of the investigation, actually, sir, infective endocarditis, there's no like the signs for infective endocarditis. Also, the blood culture is sterile, and the echo is also showing no cross vegetation. So most likely this can be managed as a case of a recurrent acute rheumatic fever.
All right. And what will you do with that severe aortic regurgitation?
So most like we can go for a valve repair or a valve replacement in this child, sir, would again be a high risk, because the PT-INRs also now they are not maintained. So the target range we are aiming is between 2 to 3, but the PT-INRs now are between is 1.29 at the time of admission. So doing again a valve replacement would subject the child even for a more risk for thromboembolic and other complications. So most like we can go for a valve repair for aortic read.
See, repairing the regurgitant aortic valve, it's a task for a surgeon. So I don't think any surgeon is going to go for a repair of this child. You rightly said, because this case is a acute rheumatic fever, again recurrence of rheumatic fever. Try to counsel the child and give him a very aggressive penicillin prophylaxis, not to miss any again episodes of gasopharyngitis. And for severe AR, you have to keep on monitoring, see the LV size, the systolic dimensions, and if his ejection fraction is preserved and the LV systolic dimensions are not increasing. So any child with LV systolic dimension of less than 50 millimeters, I would say it's all acceptable and no need for repair. In symptomatic child, if the dimension, the LV systolic dimensions are increasing, then something has to be done for this aortic regurgitation. With one surgery before redo surgery will be very, very high risk. And nowadays, of course, the age of the child is only 13. But if we can push on for another 7 or 8 or 9 years, and if child requires surgery, now we have a transcatheter aortic wall replacements also, where we can do aortic wall replacement without surgery.
Okay,
So
sir.
in near future, that could be the one of the ways to manage this child. Or if you are doing a surgery, as you said, subjecting child for the metallic valve would be, double metallic valve would be difficult. So there is a possibility of option of tissue wall replacement also. So we can go for a bioprosthetic wall replacement for the aortic valve.
Yes. Okay.
Other teachers can ask anything.
So, Dr. Rajat, what could be an option if this child is only 10 to 13 years of the age?
Yes,
So
sir.
there is one more option that surgeon have to create a one valve disease to a two valve disease. Basically, in a case of AR, mostly done in congenital AR. That is a Ross procedure. In a Ross procedure, what they do, they they go for a transplantation of pulmonary valve in place of aortic valve, and put a homograft in the place of pulmonary valve. So what they are creating, they are putting a normal pulmonary valve at the place of aortic valve, and then a cadaveric homograft is placed at the place of pulmonary valve. So that could be a one way of means dealing with this early onset AR.
Okay, sir.
Second is in your case, as the ASO titer is very high and the child looks to be in the active carditis, I think the medical management of this child would suffice. Means it can give some time for a child to grow up. If the with the medicine child can tolerate the medications, then we can delay the surgery up to an extent that child uh, develop into an adult.
Yes.
So
Can
in
the
any
experts
acute
just
disease,
throw
yeah.
some light on management of active carditis for our PGs? The medical management.
Ma'am, the medical carditis would mainly include strict bed rest with aspirin and corticosteroid as a mainstay of therapy. So, aspirin, ma'am, we initially start at a high dose of 100 milligrams per kg, then gradually taper it over around 4 to 6 weeks.
So, Dr. Rajat, when will you use the steroids? I mean, you start both aspirin and prednisolone, or usually for how long?
So usually when we are trying to taper off or omit the steroid, that is the time when we give a aspirin cover. So in order to prevent the rebound inflammation which might occur.
Right. Anybody else want to ask a question?
Yes, sir. Rajat, so we don't have X-ray of this patient or ECG?
Ma'am, actually the images were not clear, ma'am. The ECG was normal and X-ray had only shown a prosthetic mitral valve. I had actually taken the pictures, but they were not clear, ma'am. The clarity was not there, so I'm not uploading.
Dr. Rajat, with already a mitral regurgitation with prosthetic valve and severe AR, I don't think ECG would be normal. So, as you are telling, it's a severe AR, means his LV is enlarged. So, you can't expect a normal ECG in such child. And there was LA-LV enlargement already you mentioned in the last 2D. So there would be LA enlargement also. The P value, the P would be already, P mitral would have been set in. So of course the ECG will not be normal. You don't have the ECG to show. ECG would be abnormal in such child.
Yes, and your clinical findings are not going and matching with the 2D echo findings. So if we can see, it's always like first is the clinical finding, then to support that clinical findings, we go for the X-ray and ECG, and the last is our 2D echo.
Yes,
Okay,
ma'am.
so if your clinical findings are telling that there is parasternal heave, there is some pulmonary valve hypertension, and there is severe AR with LV enlargement, then it should reflect on the X-ray and ECG both.
Yes, ma'am.
So I'm looking at the other comment. So Dr. Prashant is asking, is it safe to undertake valve repair or replacement surgeries in a setting of acute rheumatic recurrence? If not, then how long does one need to wait to intervene, considering the inflammation subside, which may help? So experts.
By chance, ये बंद कर दो ना.
So definitely in setting of this carditis, we should not go for, we should not offer surgeries to this child. First, we should do the medical management in the form of decreasing the inflammation by aspirin and the steroids. And once it comes down, then only we could assess that is there any means once we decrease the carditis, the AR may have a decrease to a moderate level. So that child could be deferred surgery, and we can prolong the the gap between the gap for the need of the surgery. So definitely in acute setting or in active carditis, we should not go for the offering the surgeries to the child.
Yes. So any other, if there are no other comments from experts, should we wind up this time? Okay. So thank you so much to both the experts, Dr. Vikas sir and Dr. Sushil sir. There are so much things in the cardiology that we learn. Dr. Neeraj, will you please mute yourself? Yep. So there are so many things in the cardiology. We learn every time there is a case. And this time there is a superb insight about the valve repairs and replacements and going ahead with those. There are also use of Valsalva maneuver, which is, we use it in so many things, and one of them in the cardiology, and it's such a deliberated and such a huge use has been described by the expert. I thank Dr. Rajat also for preparing such a nice case and to present in this platform. And his mentor, he also, Dr. Prashant sir, he also deserves a clap for preparing the students and encouraging them for this. So thank you so much. Vaishali ma'am.
Thank you so much.
Yes, thanks, Dr. Nehal, for taking over. Yeah, I had some issues in the beginning. Just one comment. If the experts can just make a point about any recent changes in the medical management of active carditis as far as the doses or duration of steroids and aspirin is concerned.
I don't think there is any change. I mean, we go if there is a severe carditis, there is no waiting to start a steroid. We will start a steroid as early as possible, and then we can switch back to aspirin for some time, and then we can stop. There's no change in, as far as my knowledge goes, in the management of carditis.
It's
Thank
obviously
you.
there is no change. I would means personally, we would give this medical management for almost 12 weeks. And with the tapering doses of the steroids and the aspirin, obviously.
And
Thank you.
one more thing, sir, if there is a ASO titer so high, so with these, any other antibiotics to be taken along with the penicillin prophylaxis, or the penicillin prophylaxis will do in this child?
I think penicillin is a gold standard, so I would be very comfortable giving the benzathine penicillin. And of course, only when the child is allergic to penicillin, we can give azithromycin. For the convenience, because the reality is, at least in Mumbai where I am practicing, getting a benzathine penicillin is some task for the patient. And once, even if he gets the penicillin, giving the penicillin again is a major task. So many of the patients are not taking benzathine penicillin just because either they are not getting or there is nobody to give them. So they are either taking the oral, the pented penicillin. All the alternative, what we are doing is we are giving the once a week of azithromycin, which also is good enough to prevent the gas pharyngitis. So if you do not have the availability of benzathine penicillin, which would be the first choice always. So in acute rheumatic fever, I would be always giving the benzathine penicillin as the first choice. There is no need to give any other cover-up antibiotic for the acute rheumatic fever per se.
That culture is already negative. So I think benzathine penicillin would suffice for these acute recurrence of acute rheumatic fever.
Yes, so that is the learning point for all the students. Don't go for the investigations. Looking at the investigation, don't start antibiotics. We are going towards the antibiotics stewardship, and that's why if when the benzathine penicillin single dose suffice, we need not to cover up with the other antibiotics, as our expert says. So again, thank you so much. Yogesh sir is there. Dr. Yogesh Parikh sir. No, he has left. Okay, so we are closing this session of today.
Thank you
Thank you
very
so
much,
much,
ma'am.
both
And
the
very well
experts.
done,
And
Thank
Thank you.
Dr.
Thank
Rajat.
you.
And I
you.
pray for his
Yeah.
better future.
Thank
Thank
you.
you, doctors,
Thank
for
you,
sharing
sir.
such
Thank
valuable
you.
insights. And thank you, ma'am, for extending us the opportunity to host the session. And I hope you had a seamless experience. So with all your due permissions, everyone, I'm closing the session for today and looking forward to hosting you again very soon. Till then, stay safe and healthy, everyone. Have a nice day. Thank you.
thank you.